So now let's talk a little bit more about succinylcholine. Succinylcholine. And let's first talk about the pharmacokinetics and pharmacodynamics. So succinylcholine is a very hydrophilic or not very lipophilic drug, which means that it has a very low volume of distribution. And because of this also has an incredibly fast onset, which is what we notice when we give it and we see our clinical effect of intubating conditions incredibly fast. And so for metabolism, succinylcholine is broken down by pseudocholinesterase, which is found in the plasma as opposed to the neuromuscular junction. And so since it has to go through the bloodstream before it can even hit the neuromuscular junction, a very small fraction, about 10%, actually hits the neuromuscular junction. And as we said before, because the pseudocholinesterase activity is essentially related to their blood volume, we have to dose this based off total body weight as opposed to the normal, maybe lean body weight that we would dose for most of our drugs. And as far as the normal time for duration, it probably lasts about 8 to 10 minutes. Now, there's quite a few states that potentially have pseudocholinesterase deficiency. We'll mention them a little bit more. So there's deficiencies, and this could be either genetic or acquired. And so let's mention a little bit about genetic deficiencies. So there are over 20 kinds of mutations can lead to pseudocholinesterase deficiency, some of them of which are clinically relevant, and some of them may have a mutation but isn't seen as far as when we give succinylcholine, leading to a prolonged paralysis. And so the more clinically relevant ones are called AF mutations or a silent mutation. And so you may have heard of a dibutane number. So let's try to describe that a little bit more. Dibutane. And so dibutane or other molecules like chloride or fluoride are known to potentially inhibit pseudocholinesterase. And so what we like to do is see whether these agents are able to inactivate the normal pseudocholinesterase, and it is unable to inhibit different forms of pseudocholinesterase that might be variants. And we can use this as a way to potentially identify different types of patients that might have an inability to react to dibutane, chloride, fluoride. So you can pretend to have a patient vial, and this has our patient blood, which will have our pseudocholinesterase enzyme, and we'll add in a substrate to see how well it breaks it down, and then we'll add in dibutane. And dibutane will inhibit the pseudocholinesterase if it's a non-variant form. And so in this way, you'll recognize how fast the substrate is potentially broken down, which can essentially tell you a marker of how much of the enzyme is normal or normally inhibited by the dibutane. And so in normal patients, we have about 80% inhibition of our pseudocholinesterase enzyme activity by dibutane. And in a heterozygote, they may have 50 to 70% inhibition. And for a homozygote, they probably have about 20% inhibition, which essentially suggests that these are quite a significant number of variant alleles for pseudocholinesterase, which identifies that it may not have a strong ability to break down succinylcholine. And so clinically, how does this apply? So in a normal patient, we may have a time for how long a patient remains apneic with succinylcholine. This time is probably around 5 minutes. So this is maybe a little bit shorter than the whole duration that we may suggest succinylcholine has of 8 to 10 minutes, because we're just talking about apnea specifically, but this will be about 5 minutes. And a heterozygote isn't really that much more clinically evident, but they may last about 15 minutes. And in the scheme of our normal surgery, this is essentially not very clinically relevant because you often will have to redose a patient with potentially rocuronium or another non-depolarizing agent afterwards. And so even though we see that there is some prolongation of 15 minutes, this really doesn't mean much to us clinically. However, we do notice that with a homozygote, they can potentially be apneic for 2 to 3 hours. And so this is a far greater amount of paralysis compared to maybe our normal heterozygote populations. And so this just is very clear that even though we have maybe a half or quarter of our enzyme activity, we have a exponentially longer amount of apnea time or prolongation of our succinylcholine. And so the patient population, we see this probably 1 in 30 as far as identifying heterozygotes, and this is maybe seen a little bit more in the European population. And for homozygotes, this is probably identified about 1 in 3,000. Now, separately, we can talk about acquired forms, and so we'll say acquired pseudocholinesterase deficiencies. And so there's a few drugs that can potentially do this, including probably one of the most famous ones is acetylcholinesterase inhibitors. And so what we've noticed is that they can potentially reduce our activity by about 50%. And this can be seen even at 30 minutes after your dose of acetylcholinesterase inhibitors. And so probably the most implicated one is also probably our most common drug, which is neostigmine. And that has a significant drop in our pseudocholinesterase activity, while pyridostigmine is slightly implicated in affecting our esterase activity. And then finally, edrophonium is kind of debated whether there is any real drop in our enzyme activity. As well, we have some other patient diseases that have been noticed to have pseudocholinesterase deficiency. So this includes liver disease. And so even though we may have a relatively large drop in our enzyme activity, we don't really notice too much significantly different as far as our clinical picture. And so what we've noticed is that maybe the apnea time of 5 minutes is maybe prolonged about 3 times longer. And so in most cases, you probably don't have to consider too much about the patient coming with liver disease and giving them succinylcholine. And another drug that has been implicated is ecothiopate, which are eye drops that patients may be taking for glaucoma, although this is a relatively older medication, so you may not see this around that much. And this has also been probably giving about 20 minutes of prolongation with our succinylcholine. Now, there are a number of other states and drugs that might lead to a variable amount of pseudocholinesterase enzyme, but may not always be readily apparent clinically. And so we'll mention that these ones are a little bit more variable. And this includes OCP, or oral contraceptive pills, pregnancy. And technically for pregnancy, they've seen that clinically this hasn't shown to be any increase in duration, and that's probably because they have an increased volume of distribution to offset the idea that they may have a prolonged time for metabolism. And this has also been potentially seen in the elderly, although relatively not clinically apparent. Some patients may have burns that might be a slightly decreased amount of enzyme activity, malnutrition, hypothermia, and esmolol. And I'll also make a mention that pseudocholinesterase deficiencies can potentially affect other types of drug breakdowns as well. And so this can also affect mivacurium, which is technically a non-depolarizing agent, and we don't really see this anymore, so you probably won't see this clinically, but mivecurim does have a breakdown due to pseudocholinesterase, and so in deficient patients, they will have a prolonged blockade due to their deficiency. And I also want to mention that which is not affected by pseudocholinesterase deficiencies are esmolol breakdown and Remy, fentanyl. And so even though esmolol can potentially cause a partial pseudocholinesterase deficiency, it itself isn't broken down by pseudocholinesterase, but general plasma cholinesterases in the blood. And so is remifentanil. And so both of these are essentially not affected by these types of deficiencies. And this might even be seen on a test where they may ask you whether these types of deficiencies might affect it. And essentially, these are not. Now let's move on to pharmacodynamics. So PD. And as far as dosing for patients, the often quoted numbers are about 1.5 to 2 milligrams per kilo. And this will give you intubating conditions at about 40 seconds, while at about 1 milligram per kilo, you might see intubating conditions a little bit slower at about 50 seconds, but obviously very quick in general. And the last thing I'll mention is the idea that if you give more, let's say over 4 milligrams per kilo, you may end up with this phase 2 block. And so as we mentioned before, our phase 2 block is likely because of either an overdose in succinylcholine or giving a second dose or potentially even over titrating infusion, which isn't really done today, but was done a few decades ago as far as a common way of keeping a patient paralyzed. And so this isn't exactly well understood, but it essentially leads to a desensitization of our receptor to acetylcholine and potentially acting on the pre-junctional side to potentially cause fade, which we see with our nerve stimulation. And so much of our phase 2 block behaves essentially like our non-depolarizers. And so we can see fade, and we can potentially have acetylcholinesterase inhibitors that might reverse our phase 2 block. But because this is very hard to predict, it's essentially suggested that you don't use this as a way of reversing the patient and ensuring that they can eventually emerge. And the suggestion is that essentially you wait out the blockade and you essentially keep them sedated and ventilated until the patient has the ability to regain their muscle movement. Now let's talk about our side effects. So, effects. As far as the heart, what we see is a potential to cause bradycardia or even asystole. And so the thought is that maybe succinylcholine, when it's broken down, has a breakdown to acetylcholine, and that can potentially cause some form of bradycardia or muscarinic effects because of the acetylcholine. And this is probably seen not with our first dose, but potentially with a second dose, especially maybe in the pediatric population, which may have a little higher increase in vagal tone. And so another effects are potentially allergy. And this happens in potentially 1 in 5 to 1 in 10,000 patients, although this is a little hard to predict because we're not giving succinylcholine as often anymore, because rocuronium is often the neuromuscular blocker of choice. Now, a little bit more controversial is fasciculations and myalgias. And so as far as succinylcholine, we know that this can potentially lead to fasciculations because we end up having a depolarizing block. And so as far as fasciculations, we see that this is probably occurring in the patient population about 90% of the time. And so this is happening because of mass muscle contraction occurring all over the body. And so because of this, we can potentially have myalgias afterwards. So about 60% of patients can have significant myalgias where they may even have to take Advil or some type of NSAIDs afterwards for 1 to 2 days because of these myalgias. This may also release a significant amount of myoglobin and CK from our muscle itself. And so these may be seen a little bit more in patients that are young and relatively fit, where they may have a higher muscle mass to potentially depolarize. So one of the thoughts is that maybe we can potentially prophylactically treat these patients and ensure that they don't get fasciculations or myalgias. And so one of these thoughts was the idea of precurization. Precurization. And this idea is that you could potentially give curare or its analog that was a little bit more common a few decades ago, which is D-turbocurane, which is a non-depolarizing muscular blocker. It's very similar to ROC. And that this might help to prevent our fasciculations and then eventually our myalgias. And so the thought process that we'll show on our neuromuscular junction is that somehow a small dose of our neuromuscular blocker will prevent the mass depolarization and fasciculations that we see, but still have the blocking effects that we see when we have succinylcholine finally bind to these receptors. And so when they started doing investigations, they found that fasciculations are more affected at the pre-junctional side. And so the thought is that maybe succinylcholine has some type of effect either at this pre-junctional receptor here that might be alpha 3 beta 2 and having a different effect other than maybe just calcium released into the cell, but maybe lead to some form of depolarization that leads to antidromic activity and moving up and then eventually down all these other types of nerve endings going to the whole motor unit, not just that one synapse that was being affected. And in this thought, there's an idea that maybe rocuronium or curare or one of our non-depolarizing agents is potentially blocking at a very low dose our pre-junctional receptor and blocking this antidromic activity, leading to our full muscle unit contraction. And now this is technically not in keeping with the concept that we had mentioned earlier that succinylcholine only binds in really high doses to our pre-junctional receptor, causing this form of fade that we might see because we have less mobilization of our vesicles to release acetylcholine. And so maybe this is due to another type of pre-junctional receptor, or our pre-junctional receptor has a different form of action leading to antidromic activity. In either way, this has led to eventually the decrease in fasciculations, and so you can very much give a very low dose of rocuronium at about 0.3 milligrams per kilo of rock. And this is a very small dose compared to what we normally give, which might be about 0.6 milligrams per kilo. And so we can mention this a little bit later, but we essentially give about 2 times the normal ED95 to get our normal neuromuscular blocking effect. And so what we often can give for our precurizing dose is about 0.03 or 10% of the ED95. And so in this format, you give a very small dose of rocuronium a couple minutes prior to you inducing this patient. And at this dose, you're able to potentially get that precurization effect with potentially blocking the pre-junctional receptor and leading to less fasciculation during the dose of succinylcholine. And so the idea would be that you give maybe a couple milligrams of rocuronium, wait a couple minutes, give your normal induction, and give succinylcholine. And this time, because we have a certain amount of blockade because of the non-depolarizing drug, we have to give a higher dose of succinylcholine. And so you may need to give something like 2 milligrams per kilo of succinylcholine just to overcome the small amount of rocuronium on board. Now, you have to be careful with not giving too much rocuronium, because if you were to give maybe higher doses at maybe, let's say, 20% of ED95, they've seen that patients start to feel the negative effects of paralysis. They feel diplopia, they feel anxiety, they feel like they have trouble breathing. And so it's really important not to overdose our rocuronium too much. Otherwise, you've given a paralytic without almost any other anesthetic agents on board. And so this patient could essentially feel the negative side effects of our paralytic. Now, the idea is that we are to prevent fasciculations, and this would prevent myalgias. However, this isn't exactly being the case, because we've still seen some forms of myalgia even after we've had a pre-dose of, let's say, rocuronium. And so they've also looked at other types of agents, including 1 milligram per kilo of lidocaine given ahead of time, and that's also been shown to prevent some form of myalgia. And we've also seen that we can give NSAIDs at, let's say, 15 to 30 milligrams of ketorolac. And this can also potentially prevent our myalgias. And so even though the thought is that these fasciculations are causing myalgias, it may be more complicated or complex, as far as it may be a result of not just the antidromic activity going up the muscle unit and going back down to affect the whole motor unit, but it may also be the post-junctional effect that we see with succinylcholine that maybe isn't prevented by our rocuronium. And in either sense, we can describe how well any of these drugs work by describing their number needed to treat. And so rocuronium is about 3, which means 1 in 3 people, if you were to give rocuronium, will get the beneficial effect of avoiding myalgia. And lidocaine is probably also about 3, so 1 in 3 patients may also get their effect. And what's actually seen to be the most effective is actually ketorolac at 2.5, which means every 2.5 patients you may see some effect as far as preventing myalgias. Not that these are too significantly different, but it's nice to recognize that we may have other types of options as far as prophylactically treating patients when you're getting a succinylcholine dose. So maybe one of the most famous types of side effects that we see with succinylcholine is hyperkalemia. And so when we give a normal dose of succinylcholine in the average patient, we end up getting roughly a change in serum potassium levels of 0.5 milliequivalents to potentially 1 milliequivalent. And this is due to succinylcholine binding to the acetylcholine receptor, depolarizing the receptor, and ending up having a rush of sodium into the cell and rush of potassium out of the cell, going into the bloodstream and increasing our serum concentration of potassium. So this isn't an increase in total body potassium, but more just a shift in extracellular potassium, but with such an acute change in potassium over a specific time period. This can still have risks to potentially arrhythmias and potentially cardiac arrest. And so this happens at 0.5 to 1 milliequivalents in the average patient, but in some patients that may have specific sensitivities, we may have upregulation of maybe more sensitive acetylcholine receptors, of immature receptors, immature gamma receptors, or potentially alpha 7 receptors. So let's talk a little bit more about that by going back to our cell. And we know that we have these immature gamma receptors and non-junctional alpha 7 receptors, and both of these can potentially be upregulated in these non-junctional spaces. And so for our immature gamma receptors, these are our receptors that are created at the time of fetal development, but then turn into mature, more stable receptors that change from this gamma subunit to this epsilon subunit. And so as far as these gamma ones, we notice that these potentially have low conductance compared to our mature receptors that are available after we're born. And so in comparison, these immature ones have slightly different conformational changes that allow for slightly less current between our ions flowing through our channel, but at the same time we end up seeing them open for longer. So open longer. And this is potentially 2 to 10 times longer. And so because of that, we can even have more potassium shift out of that cell because it's open for so long, which means when we give succinylcholine, these receptors specifically may release far more potassium, and especially if they've been upregulated in specific patient populations. Now, this is the opposite for ROC in the sense that you may have to actually give a higher dose of rocuronium to get blockade because they may be more insensitive because of these potential differences in conformational changes of the channel. Now, in a similar fashion, our alpha-7 receptors also have a sensitivity to depolarization, especially with succinylcholine. And they have 5 subunits that are all exactly the same, these alpha-7 receptors. And a few notes about that. And so because they have 5 receptors that can all potentially bind acetylcholine, they have a significant sensitivity for binding. And so even with a very small amount of acetylcholine available, this channel can be activated and release sodium in and release potassium out. Now, a second point about these is that choline, which is a breakdown product of our acetylcholine, is often a partial agonist to our channel itself. And this is probably only a partial agonist because we end up having more desensitization to a choline molecule with this channel. Now, the problem with these alpha-7 receptors is that they don't end up getting this desensitization, and so choline is a full agonist. Which means again that this may be even more sensitive to the risks of hyperkalemia or extended potassium release. And then lastly, when we do give rocuronium to these channels, even if you end up blocking, let's say 3 receptors with our rocuronium drug, we still end up having 2 receptors that can still bind acetylcholine. And even if only 1 or 2 subunits have acetylcholine bound, it can still induce our conformational change and open up our channel. And so this is still sensitive with our partial non-depolarizer on board. And so what ends up happening in these patients that might have risks for upregulation is that they upregulate these immature and alpha-7 receptors in non-junctional spots, as opposed to where alpha-7 may also be in normal end plate zones and in neuronal cells. And these non-junctional spots are incredibly sensitive to our succinylcholine and end up having a significant release of potassium, leading to potentially a hyperkalemic crisis or even cardiac arrest. So this can end up being upregulated in very specific patient populations, including patients that have some form of myopathy or degenerative disease. And this includes burns, where we find that after a significant 3rd-degree burn, they may have an upregulation of receptors within the next 1 to 2 days, which then leads to a significant hyperkalemic when they're given potentially succinylcholine. And so this is essentially a very strong contraindication to giving succinylcholine. This, however, returns back to potentially normal in 1 to 2 years. 1 to 2 years. And which it may be safe to give succinylcholine. However, there's still been reports of a hyperkalemic attack, potentially 2 years after a burn injury. Now, other types of diseases include myopathy and degeneration. And this is due to the nerve receptor becoming less and less activated because a patient has some type of myopathy or inability to move that muscle or limb. And this leads to an upregulation of these types of receptors, immature and alpha-7, to ensure that they get some amount of activity to potentially sense those very small amounts of neurologic transmission because they have this degeneration. And so this happens for a lot of these patients with myopathy and degeneration, and also happens even with immobilization. And so let's say a patient is even bedbound for a few days on the ward or potentially the ICU. These patients can upregulate these receptors as well and potentially have hyperkalemic crisis. And so they've done a study in the ICU population where they've noticed that bedbound patients, after even 7 days, can potentially have an increase in 2 milliequivalents of potassium. And they also noticed that probably around 20 days, they could potentially have an increase in 5 milliequivalents of potassium. And this is a change in 5 milliequivalents of potassium. And so a change in 5 milliequivalents would almost guarantee an arrhythmia or potentially cardiac arrest. And so we have to be very careful about potentially giving succinylcholine to patients in our high-risk populations like burns, degenerative, and myopathy patients. But we even have to be careful with a patient that may be on the ward for, let's say, 5 to 10 days, because they may also have some amount of upregulation. And so let's say you were called to the ward to potentially intubate a patient that has had respiratory distress and has been admitted with, let's say, pneumonia for the last few days. You have to consider that maybe there is a chance for a hyperkalemic attack even in this patient as well, even if they don't have a very specific type of patient disease that you think puts them at a higher risk of a hyperkalemic crisis. So a few more effects that we'll talk about include GI, and this includes an increase in gastric pressure. And so you might think that this has an increased risk of aspiration in patients where you're giving succinylcholine, which if anything is very concerning because we often give succinylcholine specifically for an RSI because we want to intubate them as soon as possible. However, this is balanced with this increase in lower esophageal sphincter tone. And so what ends up happening is that if we have our esophagus here and our stomach here, what we have is our lower esophageal sphincter, and we have our gastric pressure. And so this contraction here can lead to increased pressure in our gastric area. But because we have this lower esophageal tone that also gets tighter, we don't end up having any ability of having these gastric contents coming up our esophagus. And so technically, this doesn't have an increased risk of aspiration. This may be a little bit higher though if the patient has something that weakens this muscle, specifically our lower esophageal sphincter tone, and that might be a patient like achalasia patients. Now as well, succinylcholine can affect eyes, and so this can potentially increase intraocular pressure, and this is due to what we mentioned before about these ocular muscles not having the same ability for accommodation, which means they maintain a significant contraction that leads to 3 to 7 millimeter increase in mercury in their globe. And so a thought process is that because they have such a sustained and increased intraocular pressure, that this may be at risk for patients that have, let's say, a globe injury where they may have an ability for extrusion of vitreal components outside of their eye. But we noticed that, at least in clinical studies, we haven't seen a clear clinical evidence of significant risk with this. Now, succinylcholine can also have an issue with masseter muscle rigidity, or MH. And so with masseter muscle rigidity, we have an increase in masseter tone. And so similarly, like our eyes, we have an increase in this tone because probably a lack of accommodation that's occurring, which may last a few minutes. And this can potentially have difficulty with intubation if you can't open their jaw well. This does relax, however, after a few minutes, but what's concerning about this is this could be a heralding sign for MH. And so there is some association with the increased masseter tone associated with succinylcholine and the idea of the patient potentially having MH. And it's likely not a full correlation in the sense that not every single patient who has increased masseter tone will have malignant hyperthermia, but this may be a sign to suggest that you should be more suspicious of the patient being at risk for malignant hyperthermia. And malignant hyperthermia is a disease where we end up having a mutation in our ranitidine receptor, or partially other small parts of our general calcium-dependent calcium release unit, which is a small mechanism near our T-tubule system, where we end up getting a propagation of our nerve signal down from our end plate down into our sarcomere from our T-tubule system, triggering our calcium to flow in and triggering a calcium-dependent calcium release of further calcium mobilization at our mitochondria. Now, the problem is if we have this mutation is that we end up having a significant amount of calcium being released. And so a significant amount of calcium rushing into the cell means that the cell has to work incredibly hard to correct this imbalance. And in doing so, it uses a large amount of ATP, gets incredibly hot, and has a high metabolic rate, which ends up eventually lysing the cells and having hyperkalemia, and potentially leading to muscle breakdown or rhabdomyolysis and acidosis. And this can be so life-threatening that the patient could actually die from this unless they get the antidote, which is essentially dantrolene. And dantrolene allows this ranitidine receptor to be uncoupled so it doesn't lead to further increased calcium into the cell. And so at the same time, because you stop calcium mobilization in the cell, you end up actually leading to weakness with dantrolene itself. And lastly, succinylcholine can affect the CNS, and this can potentially increase ICP. And this is due to muscle fasciculations around the head, leading to increased stimulation of our brain and increased CMRO2, or metabolic rate of the brain, which also then leads to increased cerebral vasodilation and cerebral blood flow to the brain. All of which then has a slight risk of increased ICP. And so even though we do have this increased ICP, this is relatively benign compared to other things that may also increase our ICP, like hypoventilation or significant stimulation. And so in some sense, it may be far more beneficial benefit versus the risk of giving succinylcholine, because we can potentially get a captured airway in a patient relatively quickly and avoid any amount of increased hypercarbia and potentially lead to cerebral vasodilation and high ICP. And the idea that when you paralyze a patient and they have a full block on board, they won't respond to your laryngoscopy with coughing and bucking, and another reason for patients to have an increased ICP. And so even though there might be this slight chance for increased ICP, there's far more benefit compared to the risk of giving succinylcholine. And so this essentially shouldn't really be a consideration as far as avoiding succinylcholine in a patient that potentially has a traumatic brain injury or some reason for increased ICP. So now let's talk about non-depolarizers. Non-depolarizers. So first thing I'll mention is that when we talk about muscle blocking effects, we talk about an ED95, and that means that there's a 95% chance that we end up having muscle blockade, so we don't have muscle contraction. Now, if we're talking about intubation, we often need more than just ED95 to ensure that we don't have any response with laryngoscopy and we don't have any difficulty with actually intubating. And so to do that, we often give 2 times the ED95 to get appropriate conditions. However, there are different muscles that are affected more or less based off our neuromuscular blockade that we're giving. And so some muscles are more resistant. And so this is the larynx and diaphragm. And so these are often resistant to our neuromuscular blockers, while our abductor pollicis, which is part of our skeletal muscle, have a slightly different sensitivity compared to our other types of muscles. And so we can draw a hand right here just to explain abductor pollicis a bit more. So it's a very common muscle that's very easy to monitor, especially intraoperatively, but potentially also in standardized research settings. And so what they do is they use an electromyographic technique to place on the hand and to monitor our thumb moving towards the rest of our hand. And this contraction is essentially representative of most of our skeletal muscle and essentially has a good sense of understanding how neuromuscularly blocked our patient is. The only thing is this is relatively sensitive compared to our larynx and diaphragm. And so these muscles are often 2 times as resistant compared to our adductor pollicis. And so for that reason, we may feel like this may not predict perfectly our normal intubating conditions. The other problem is that we also have blood flow going to different organs at different speeds. And so even though you might think that the larynx and diaphragm might have a slower onset because they're more resistant to our neuromuscular blocker, they also have faster blood flow because it's a more central organ compared to our adductor pollicis, which is in our extremities. And so because of this, we actually may notice a faster onset at our larynx and diaphragm, even though they're more resistant. And then because they're more resistant, when we're looking at emergence or extubation and we're looking for how long this neuromuscular blocker lasts at each site, the more sensitive one will last longer. And so we end up finding that at emergence, our diaphragm and larynx actually return back to normal function first. And so it's also faster off. And so you may notice this clinically when you may have a case and you're at the middle or end of it and your neuromuscular blocker is wearing off, and you notice that the diaphragm is potentially moving and the patient is starting to breathe against your ventilator. And this might be happening even though you might be seeing a relatively strong twitch depression because you have a reasonable amount of neuromuscular blocker on board, but it's more sensitive to your adductor pollicis, and so it may not be predicting your diaphragmatic movement. Now, the next thing I want to mention is the idea of priming. And so priming is this concept that we can potentially give a small amount of neuromuscular blocker ahead of time, and when we then give our full dose, maybe 3, 4, 5 minutes later, we end up finding a faster onset. And so this dose is about 10 to 15% of the normal intubating dose. And so the concept is that we may have multiple acetylcholinesterase receptors, but we know that we have this margin of safety where we end up needing a significant amount of blockade before you can get to reasonable muscle contraction blocking. And so this is called our margin of safety, and essentially means that we need about 75% blockade before we can even get a small amount of muscle contraction to be depressed. And so the concept is that we could potentially give a small amount of drug so that we've blocked a certain amount of receptors, and then when we give our final dose, it only needs to block a smaller percentage to eventually get to our neuromuscular blocking effects. And so we might find that with our normal dose for intubation, we might find that it takes 1.5 to 2 minutes. But with a priming ability, we might see that it drops down to about 1 minute. Now, another way to potentially have a faster onset is to increase the dose. And so this might lead to us giving 3 to 4 times the ED95 compared to maybe the 2 times ED95 of our normal intubating dose. And in the same respect, if we have a 1.5 to 2 minute intubating time, with a higher dose of rock, it can lead to about intubating conditions at about 1 minute. And so this is what we might do in a modified RSI if we were to give rocuronium at high doses compared to, let's say, the normal succinylcholine RSI. The only problem with this is that this might lead to a prolonged effect or longer duration because we've ended up giving more neuromuscular blocker in the end. And so when we would normally expect this to be 45 minutes, we now see this may last 60 minutes. And so there might be a downside to giving a higher dose of neuromuscular blockers, especially if you may have a shorter case. But there's also a downside to our priming in the sense that you may be giving this small dose of neuromuscular blocker prior to the patient fully getting an anesthetic agent. And so if they aren't anesthetized and they are fully aware, they may feel diplopia or trouble breathing or agitation. And this could be relatively unpleasant for the patient when they don't have any other agents on board. And so we have to be careful not to give them more than this, as this could potentially lead to adverse events in the patient, which occurs when we give a pre-dose of non-depolarizers before we give succinylcholine, which is different from us potentially priming with the same non-depolarizer, let's say a small dose of rock, prior to giving a higher dose of rock. And the concept of pre-curization is only to facilitate avoiding fasciculations and potentially myalgias, while priming is only involved in increasing the speed of onset of the drug. And then the last thing I want to mention is that most non-depolarizers have this ability for potentiation. And so this happens with a lot of different drugs that we might see, where we might see an added or synergistic effect with another type of agent. And so this includes volatiles, which we mentioned might act by desensitizing the acetylcholine receptor. It might happen with magnesium, which competes for calcium at the pre-junctional nerve terminal and then avoids this mobilization and further acetylcholine release. Or it can happen with local anesthetics, which might happen with desensitization or direct channel blocking effects, where it can block the sodium channel when it's opened and have a use-dependent block in directly blocking this channel and avoiding depolarization. And so these ones might be due to a secondary mechanism of action leading to synergy, because there's two different areas in which we have nerve terminal blockade. Now, this is different from potentially antiarrhythmics and potentially inhibiting drugs like anticonvulsants. And so both of these are potentially changed by our CYP enzyme. And what we find is that we can potentially have inhibition of our CYP enzyme by antiarrhythmics, which then changes the way that neuromuscular blockers might be broken down in our body. And as well, we can potentially induce CYP enzyme and potentially have an extremely fast amount of neuromuscular blocking metabolism. And if it's significantly increased, then we end up having a very short duration of action. And so this is often seen with patients on Dilantin chronically. And so if these patients were to come into the operating room, you might find that giving your normal intubating dose of rocuronium, that the patient has metabolized that so quickly that they're probably breathing 10 or 15 minutes after you've given that normal rocuronium dose. So let's talk about our classes of non-depolarizers. So we'll mention rock. We'll talk about vecuronium and pancuronium. And we'll also talk about cisatracurium and atracurium. So first thing we'll mention is that these three are steroid drugs. While these drugs, cisatracurium and atracurium, are benzylisoquinolines. And so we'll differentiate these two classes, and the idea is that they have different molecular structures and that steroids often are considered vagolytic, while benzylisoquinolines are considered to give a large histamine release. And so even though we'll mention that this classification for steroids versus benzylisoquinolines used to be maybe more important, nowadays we have two new agents, vecuronium and rocuronium, that are still steroid non-depolarizing agents, but they don't have the same vagolytic activity that pancuronium used to have. And so because of that, some of these distinctions may not be as evident, but it's still good to know from a historical perspective that these are benzylisoquinolines and these are steroids. Now let's first talk about our pharmacokinetics, or PK. And so all of these agents are relatively short acting except for pancuronium, which is very long acting in comparison. These are short. And so pancuronium can probably last about 1 to 2 hours, while all our other agents are roughly around the 30-minute mark, give or take. And another thing that's relatively common between all our non-depolarizing agents is that they all have a relatively small volume of distribution. They all happen to be very hydrophilic, and that this leads to us having a very fast onset of action. Now, you might think about our IV agents and how they were lipophilic and they had a very fast action, but these are hydrophilic and these have fast action. And the difference is that the side effect from where they're actually acting is different. So this is not the brain this time, but this is the muscle. So we actually do want our drug to distribute to all these muscles and tissues in our vascular space. I don't specifically want it to cross, let's say, a blood-brain barrier. And so if anything, a hydrophilic drug has a better, faster onset of action for muscles compared to a lipophilic drug, which has a better effect for sedation. And so we'll say all these agents, including succinylcholine and our non-depolarizing agents, are hydrophilic, while all our sedative medications that we end up using clinically are all lipophilic. Now, as far as the ED95, we can describe our agents based off this, and we'll say these are milligrams per kilo. And we'll say that this is related to its potency, but also related to its onset. So we'll write onset below this. And we'll start to look at why there is this relationship. So rocuronium has a ED95 of about 0.3, which is half of what we normally give as far as an intubating dose, which is roughly 0.6 milligrams per kilo. And this is different from vecuronium, which is a dose of about 0.05. And pancuronium, which is 0.07, both of which are far more potent than potentially rocuronium. Cisatracurium also is significantly potent, while atracurium is less potent at 0.2. Now, if we're to describe the onsets, we know that rocuronium is very fast at about 1.5 to 3 minutes. We know that vecuronium is about 3 to 4 minutes. And pancuronium is about 2 to 4 minutes. While cisatracurium is very long at 5 to 7 minutes. And atracurium is a bit faster at 3 to 4 minutes. And we'll just describe succinylcholine just to have a good comparison here. So succinylcholine's ED95 is 0.3, which is very different from our intubating dose where we can potentially give 1.5, which is 4 to 6 times our normal ED95. And this allows us to get incredibly fast onsets of action, where we may see 1 to 1.5 minutes if we give a lower dose of sux, but at extremely high doses of sux, we can end up getting intubating conditions at about 40 or 50 seconds. And so what I really want to mention here is the idea of potency and the idea of onset of action. And so the normal thing you would expect is that a higher potent agent would be faster onset as far as giving you muscle blockade. But in this instance, it's actually the opposite. And so what we find is that the more potent drugs like vecuronium and pancuronium and potentially cisatracurium, these drugs have very long onsets, 3 to 4, potentially even 7 minutes, while other drugs that are a little bit less potent like atracurium are a bit faster, and even faster than that is probably rocuronium and succinylcholine. And so the reason why is that we think that when we give a drug, the more potent the agent, the less there actually is of any one agent to potentially block these receptors. which means if we end up giving a low potent agent, there's actually more molecules around to potentially block these receptors and lead to a faster onset of action, even if it's not as strong. And so with a low potent agent where you give more molecules, you may end up getting more blockade at a faster rate, which ends up having a faster onset of action. Now let's talk about cis-atracurium and atracurium, these benzylisoquinolines, because this will make a little bit more sense why we talk about potency and the idea of onset. So let's go into the metabolism and excretion of our pharmacokinetics. And so we know that with cis-atracurium and atracurium, these benzylisoquinolines, that they're broken down by two mechanisms: ester hydrolysis and Hoffman elimination. And so this is very similar to our remifentanil, where we end up having ester hydrolysis of our molecule into two different breakdown products. And this is not related to our pseudocholinesterase, but other esters that are non-specific and lead to our hydrolysis and breakdown of our atracurium and cis-atracurium. And as well, we have Hoffman elimination. And remember, the same thing occurs with remifentanil, where when you inject the medication into the serum, it has a natural degradation, irrespective of any enzyme breaking it down. And so with these two forms of breakdown, we essentially don't have any breakdown with our liver, and we essentially only have excretion through our kidneys. And so this is very useful for potentially infusions, because we know that we can predict the offset time because we know that it doesn't build up over time. And so for cis-atracurium, we often see infusions of about 2 to 4 mics per kilo per minute. Now, I will say that there are some potential detrimental things associated with our benzylisoquinolines, and so we'll talk about side effects as well. And so one of the big side effects is histamine release. And there's such a significant histamine release that we notice that we can have lower blood pressure, and this is through vasodilation and venodilation, which would drop our preload and afterload. And this can also cause a significant amount of bronchospasm. And this can happen more if we end up giving overdoses of these medications, or if maybe the patient is sensitive to these like bronchospasm or asthma. And then the next thing I want to mention is this idea of ladonazine. And so one of these breakdown products of Hoffman elimination is ladonazine. And this breakdown product is normally broken down by the liver to be further metabolized, but if it can potentially build up, it can cause CNS toxicity. And this can potentially lead to seizures. And so there are some potentially detrimental effects to our benzylisoquinolines, and this can especially occur if the patient has liver failure, which means that ladonazine can potentially build up even more. And then lastly, because we know that this is due to blood serum breakdown as opposed to being broken down in the liver, this is especially sensitive to hypothermia or potentially acidosis. And both these can potentially prolong our effect of our benzylisoquinolines because they're dependent on these serum breakdown methods. Now, I'll say that this mostly describes atracurium. And so atracurium has multiple types of stereoisomers, one of which is cis-atracurium. And this is in probably about 15% of atracurium. But if you just isolate just cis-atracurium, we find that cis-atracurium by itself is about 4 times as potent. And this makes sense based off the ED95s, that cis-atracurium is about 0.05, while atracurium is about 0.2. Now you may think you may not want to use this because the onset time is much longer with a potent neuromuscular blocker compared to a non-potent one. But there's a lot of benefits to having the potent one because what we end up having is less histamine release because we have 4 times less molecules in the patient in their serum concentration, which means we have far less blood pressure changes and far less bronchospasm. And so even in clinical doses that might be 2 times as much or 3 times as much, we don't see our histamine release having a clinical significance. And as well, because we have less of the actual molecule around, we also have less ladonazine metabolites being produced. And so there's less issues with toxicity with cisatracurium and less issues with histamine release and cardiovascular collapse with cisatracurium. And so it's ended up becoming more and more favored compared to atracurium. So just to explain this a little bit further, let's talk about intubation dose. And so, as we said before, the normal intubation dose that we look at is about 2 times the dose or 2 times the ED95. So this applies to all of our steroid non-depolarizers. And this also applies to our normal atracurium, so 2 times the normal ED95. And this is because we don't want to give anything more because we start to find some of these side effects like histamine and ladonazine breakdown. And so we often don't want to go higher than 2 times this ED95. This, however, isn't the case for cisatracurium, and we can potentially give 4 times the ED95 here. And giving 4 times the ED95 can potentially speed up our onset of cisatracurium. And so if we potentially give 4 times this, we'll end up having a very fast onset of action, which might be in the order of 2 to 3 minutes. But we also realize that if we give a higher dose, we also end up having a prolonged effect. So this might prolong it up to about 1 hour, when normally we might expect cisatracurium to last maybe 25-30 minutes. And so the second way that we know we can potentially have a faster onset is this idea of priming. And so what we can do is potentially load the receptor with a small dose of cisatracurium. And then when we give our next dose of cisatracurium a little bit later, we can end up having a much faster onset because we don't have to block as many neuromuscular acetylcholine receptors. And so with priming, we could give potentially 2 times a dose and still have a relatively fast onset. But like we said before, there may be some difficulty with the patient feeling diplopia or anxiety or trouble breathing. And so you'd have to be relatively careful about the dose that you give for priming. So now, due to this ability for cisatracurium to be very, very potent and avoid our abilities for histamine and ladonazine to occur, and at the same time we can dose it very high and potentially have a very fast onset of action, cisatracurium works very well in the clinical setting. And if anything, works incredibly well with infusions because we know that we can predict its offset. Now let's talk a little bit more about our steroid non-depolarizers. And so the first thing we'll talk about is pancuronium. And pancuronium has some active metabolites and is often cleared by the kidneys or the renal system and only has a small amount of clearance by our biliary system. And so this might be affected both by liver failure and kidney failure. In kidney failure because it may not be cleared as quickly, and as well in liver failure because there might be some active metabolites that occur that have prolonged sites of action. And as far as side effects, pancuronium is notorious for catecholamines and its vagolytic action, which means that we can have a significant amount of tachycardia with our administration, and this can potentially cause arrhythmias. And as we said, this is very specific to pancuronium and not really seen with our newer agents like vecuronium and rocuronium, which are now one of the more favored agents. And the second reason that we often favor these agents is that this is incredibly long acting. So these last about 1 to 2 hours. And because pain can last so long, we can potentially have residual block. And so what can happen is that because it's so long acting, either it might be difficult to give a reversal agent, or we may give a reversal agent that might be shorter acting, then how long pancuronium may last. And so you may find a second phasic response where the reversal is worn off in PACU or in recovery, and then the patient becomes more paralyzed and has more trouble breathing. And this is very similar to this concept of even giving morphine and then giving naloxone, where naloxone might have a shorter duration compared to morphine or other long-acting agents. Now, a shorter acting agent that came just slightly after pancuronium is vecuronium, and this has some active metabolites as well. About 12% are active metabolites, and it's excreted mostly by our biliary system and some excretion by our kidneys, so about 40% by our renal system and 60% by our biliary system. And so in the same respect, liver failure and kidney failure might be detrimental if you give these agents. Liver failure because you may have some inability to have biliary excretion, and you may have some buildup of active metabolites, and kidney failure because we have poor excretion because of this 40%. And this is different from rocuronium, which is our probably newest agent and most common, and this is where they have no metabolites, and this is mostly cleared out of our biliary system at about 90%. While we have probably about 10% clearance from our renal system. And so in rocuronium, it's incredibly sensitive to liver failure because we end up having a very poor excretion of the unchanged rocuronium, while we only have a small amount in, let's say, kidney failure that might be affected. And since there is a little bit of clearance through our kidneys, we may have the smallest effect where they've noticed that the average time for how long rocuronium lasts in a patient with kidney failure is about the same, but there's more variability with how long it lasts. And so with these wider standard deviations, this may be due to some patients having more clearance through our kidneys, and that this leads to patient variability, and some patients with renal failure may have a longer time with rocuronium. And so in both liver failure and kidney failure, we may end up having a little bit of variability, potentially a long, prolonged duration of action with some of our drugs, which may lead us to use instead cisatracurium, where we know that it's independent of liver failure and kidney failure and will have ester hydrolysis and Hoffman elimination. Now, the general benefit of rocuronium and vecuronium is that there are no CV effects or histamine release. And so this may be relatively safe to give more than 2 times our normal ED95 for intubation and potentially get faster onsets. Now, just to compare, rocuronium probably lasts about 30 to 45 minutes, while vecuronium is more in the range of 60 to 90 minutes. And so even though you may want to give a higher than 2 times intubating dose for vecuronium to make up for the fact that it's more potent and has a slower onset time, this makes it potentially incredibly long, even to the point of seeming like pancuronium as far as its duration of action. And so a common strategy that people did was they would prime this or give a priming dose similar to what we talked about with potentially cisatracurium. And in this sense, you didn't have to give 3 or 4 times dose of ED95 and lead to prolonged duration of action. But at the same time, it was at the cost of potentially making the patient have a few feelings of the blocker before they fully had their anesthetic on board. But after ROC came out and it became an even less potent form of vecuronium, and it also didn't have our CV and histamine effects, we were potentially able to give a higher dose than 2 times the ED95. And this is what we see in RSIs. And with an acceptably reasonably long duration time of maybe 60 minutes, it seems acceptable that we could potentially do a modified rapid sequence induction with rocuronium. And because rocuronium is less potent and has a faster onset time, priming became less and less common. So often you may not see anesthetists giving a priming dose of rocuronium because the onset of action is so quick in and of itself. Now, I will say that there are some side effects that are being reported, including allergy. And this has had a very wide range. And so allergy has been noted to affect 1 in 5,000 patients, to potentially 1 in 1 million patients. And this is really different based off our patient population that we're testing. And so the 1 in 5,000 patients has been very common in European patients, or especially French patients. And this has not been the case in potentially the North American patient, where the rate has been closer to 1 in 1 million. And so an idea that was suggested was that this is due to certain differences in drug exposures that the patients have had in other settings. And one drug that has been implicated is called folklodine. And this drug has been known to be in cough syrups, especially in Europe, and that maybe there's some cross-reactivity with folklodine to rocuronium, and that the patient population in Europe that's having folklodine exposure has a more sensitivity to rocuronium and allergy afterwards, leading to the idea of anaphylaxis in 1 in 5,000 patients, while the incredibly rare 1 in 1 million patients in North America because we don't have an exposure to folklodine. And so they've shown that the amount of folklodine exposure has been correlated with the amount of anaphylaxis in that population related to rocuronium dosing. And so now that we've talked about our general classes of benzylisoquinolines and our steroids and our most common types of neuromuscular blockers, I'll mention another one that we used to have and is not available in North America anymore, but is more common in Europe, is called mivacurium. And this is also a benzylisoquinoline that also has histamine release, but has probably a far more shorter time frame. So this probably lasts about 10 to 15 minutes. And so is relatively short acting and acts essentially very similar to succinylcholine, although this is a non-depolarizing agent, while succinylcholine is a depolarizing agent. And this short-acting mivacurium also not just has ester hydrolysis, but has specifically pseudocholinesterase hydrolysis. And so, like we see with succinylcholine, pseudocholinesterase deficient patients may have an issue with breaking down mivacurium, and they may have a prolonged duration of action. This is also similar to patients potentially with liver failure that may have a prolonged action because of poor pseudocholinesterase activity. And then lastly, I want to mention this idea that a lot of our short-acting agents, ROC and VEC, and cisatracurium and atracurium, they all have relatively short durations of actions, or maybe intermediate durations of action, but this is due to different reasons. And so we can point to the benzoquinolines as having ester hydrolysis and Hofmann elimination, which means that when you look at the concept of how long this action actually lasts in the body, the offset of the drug is due to elimination. And this is because it doesn't have time to distribute to other types of tissues, and that it is essentially broken down relatively quickly in our bloodstream. This is very different from our rocuronium and vecuronium, where these distribute to other types of tissues as well. And so the offset of this is due to distribution. And so even though our half-life of ROC and vecuronium might be longer, might be the order of 90 minutes or even longer, that this doesn't really describe the offset of rocuronium and vecuronium, and that they offset because it redistributes into these other compartments and eventually doesn't have its effect on its muscle specifically. And so this can be clinically relevant when you're thinking about running an infusion. When you run an infusion, these medications over a long time period start to build up in those other compartments. While if you consider the idea of cisatracurium, an infusion won't build up and you'll still have a very consistent off time or decrement time for your infusion. When you run, say, very long infusions for, let's say, half a day or 6 hours, you may end up having a prolonged blockade because you're running the same amount of neuromuscular blocker and it continues to build up in these different compartments and eventually seep back into the central compartment when you end up turning off your infusion. And so for very long cases where you may want to have them paralyzed for a large percentage of the case, or if they may have liver failure or kidney failure, you may choose to give cis-atracurium instead of potentially rocuronium for those reasons. So for our next section, we'll talk about the idea of drug interactions that potentially interact with both our depolarizers and non-depolarized to essentially review what the comparison is between them. And so remember we talked about classical and non-classical types of blockade, as well as desensitization, direct channel blocking, and pre-junctional blockade. And so we'll talk about both depolarizing and non-depolarizing. And so we'll first mention antibiotics and how this both potentiates depolarizing and non-depolarizing. And this is likely due to some type of CYP enzyme inhibition. And this is mostly with older medications like streptomycin, neomycin, and polymyxin. Now, there are a few other antibiotic medications that have been implicated with maybe a very slight or minor change in prolongation of neuromuscular blocker, but essentially not seen at the clinical doses that we use. And so that includes aminoglycosides and flagyl, lincosamides like clindamycin and lincomycin, penicillins, cephalosporins, tetracycline, and erythromycin. And so essentially the medications that we use currently are probably not ones that are going to interact with our neuromuscular blockers. Now as well, anticonvulsants, which we've mentioned before, can inhibit non-depolarizers, and especially in that concept of enzyme induction to essentially speed up liver metabolism of our non-depolarizer. And I'll just make a note that this is not related to benzylisoquinolines. And this is because benzylisoquinolines are metabolized by ester hydrolysis and Hofmann elimination in the blood, and so are unrelated to the idea of liver metabolism. Now we mentioned antiarrhythmics. And this can potentially do a very similar enzyme inhibition. And this is specifically related to quinidine. And even though maybe some calcium channel blockers have been identified as potentially having some positive neuromuscular blocking prolongation, like verapamil and amlodipine, this is essentially clinically insignificant. And so we don't see much with our calcium channel blockers. And like before, we've mentioned acetylcholinesterase inhibitors, which mess up pseudocholinesterase enzymes, as well as potentially desensitization of our non-classical pathways for nerve transmission or blockade. And this is specifically very positive for neo and potentially pyridostigmine as well. And this has a positive blockade for our succinylcholine or depolarizing drugs and an inhibition because we have less acetylcholinesterase in the synapse to break down acetylcholine, and this leads to further acetylcholine outcompeting our rocuronium or other non-depolarizers. We also have dantrolene, which essentially stops the ability for calcium to be brought into our cytoplasm. And so in that sense, it potentially weakens your muscle, and non-depolarizers have an easier time with blockade. Obviously, this is the treatment, however, for malignant hyperthermia. And so you shouldn't ever avoid this just because you think the patient may have some prolonged amount of muscle weakness or paralysis, but just know that you might expect some amount of prolonged ventilation when you've given a significant amount of dantrolene to potentially treat malignant hyperthermia. Now as well, volatiles, which we've mentioned before, maybe has some thought of desensitization or other actions pre or post-terminal. And this can affect both depolarizers and non-depolarizers. And this is mostly seen with DES and SIVO. and a little less so than the rest of our volatiles. And that's likely because these are relatively fast-acting agents, and so they can distribute to our muscle sites much faster than probably our other agents that are much slower onsets. Because we know that both our DES and SIVO have relatively low lipid solubility, which means that their onset of action is much stronger because they can get to an equilibrium with their alveolar partial pressure, which essentially is equal to the partial pressure of their brain and other tissue sites. And so other medications include ketamine. And this has ability to potentially prolong non-depolarizer muscle blockers. And this probably has something to do with our spinal cord inhibition at the site of our dorsal horn. As well, local anesthetics, which we've mentioned before, can act with direct channel blocking effects or potentially pre-junctional. And so this can block depolarizing as well as non-depolarizing agents since it's acting at a different mechanism of action. And so this is affecting both pre and post, as well as potentially at the muscle itself. And so they may be acting at the pre-synapse, the post-synapse, as well as potentially at the muscle. And this is thought to be displacing calcium to potentially lead to worse muscle contraction. And this is mostly seen at high doses. Now, separately, lithium has been known to both increase depolarizing and non-depolarizing, and this may be from a similar mechanism with both pre- and post-junctional effects. Now, magnesium, which we've mentioned before, can potentiate both depolarizing and non-depolarizing, and this is from another point of secondary mechanisms of action, and this is at that pre-junctional nerve terminal. And this outcompetes calcium for entry into the cell and prevents mobilization of acetylcholine and release into that synapse. Now, this has also been used as a thought to avoid muscle fasciculations, and this does help to stop that. So this can stop fasciculations, but it has been found that it doesn't actually prevent myalgia. And so there's no evidence that giving a dose of magnesium prior to you giving succinylcholine has a positive effect for the patient. And the last medication we'll mention is Lasix. And so Lasix specifically as a diuretic can increase or prolong depolarizing and non-depolarizers. And this is due to potentially inhibiting or lowering cAMP and in turn ATP breakdown in the cell. And this will lead to less acetylcholine at the nerve terminal and less release into that synapse. And I'll mention that this is only with acute doses of Lasix at about maybe 1 milligram per kilo. When a patient is potentially on chronic Lasix, this effect isn't seen. And this is different from other types of diuretics like, let's say, mannitol, where that's more of an osmotic diuresis and doesn't affect our neuromuscular blocking at all. And then finally, we can talk about combination of certain types of neuromuscular blockers and what happens with them. And so what we can say is they can potentially have same class neuromuscular blockers, different class, or serial dosing. And each of these have potentially slightly different effects. And so for same class, because of the mechanism action is at the exact same site, they're essentially additive. And so we can map out these ED95s and say that one of our drugs is 0.5 of, let's say, atracurium.
Let's say we have half an ED95 of cisatracurium. Together, this would equal 1 ED95.
Now, this is different from, let's say, different classes of non-depolarizer muscle blockers, because what we can see there is synergy. And so synergy is that when they have two different types of mechanisms, we can see more than just an additive effect, and we see a very, very strong, potentially exponential effect. And so let's say we're going to have 0.25 of a ED95 dose of, let's say, cisatracurium, and then let's potentially also add 0.25 of rocuronium. And so because one is a benzylisoquinoline and another one is a steroid non-depolarizer, even though this would normally add up to 0.5 of an ED95, in this respect, this might add up to a full dose of an ED95. And so it's important to recognize when maybe these classes of agents can be additive or synergistic. And then as well, we can talk about serial dosing of, let's say, one drug and then another. And what we'll say is that the first drug determines the kinetics. And what I mean by that is that the first drug binds to a bunch of these receptors and fills up most of them. And then what we end up seeing is the block actually responsible based off the last fraction of acetylcholine receptors that need to be blocked. And so what we see is that potentially the second drug, when it's metabolized, we end up seeing the more pharmacokinetics of the first drug because it's filled up all these different receptors. And so in that sense, if you were to first give pancuronium, which is a very long-acting medication, and then the second dose maybe is rocuronium, what we see is that the rock lasts longer. And it's probably not technically the rock that's lasting longer, but that the paralysis in general is lasting longer than we'd expect for rocuronium. And then separately, if we were to potentially give rock first and then pancuronium, what we'd see is that the panc doesn't last as long as you'd normally expect. So it lasts less. And that's probably because these receptors that are filled are probably mostly filled with rocuronium, and so the leftover effect is probably shorter than you'd normally expect for pancuronium. And so I'll make one more note about the potential for succinylcholine, which if you give after a non-depolarizing block, so we give this second, then there's two potential effects. If the patient had a deep blockade, then we notice that this is an antagonism. And this is probably due to the concept that when you have a certain amount of neuromuscular blockers on board with some of these acetylcholine receptors, there's less receptors available for succinylcholine to bind, which means there's less ability for sux to have its depolarizing effect. Now, separately, if you have a shallow blockade, then you can have potentiation of your blockade. And so this is a little harder to explain, but probably has to do with our non-classical pathways for neuromuscular blocking and some form of desensitization of that channel, including that you have another non-depolarizing blocker on board through a secondary mechanism to essentially have some form of synergy. And so hopefully this helps to understand a little bit more about depolarizing and non-depolarizing drugs and how they're acting at the nerve terminal and synapse to potentially affect our patient's muscle relaxation.